Okay, we're live.
Hey, good day, everyone, and you're welcome to ATP live session on Fresh Waves Radio. And I'm glad to have Dr. Wemisola Boyede here again. It's been a while we've done this together, and it has always been an amazing moment, and also um, getting to hear from ATP all the time, every week on Fresh Waves Radio. So we are glad that you are doing this with us today. You're welcome, ma.
Right. Good morning, everyone. For those who are watching on Instagram as well, even though you can't see Esther, but I'm sure you can hear her. Good morning, everyone. Welcome to ATP Hour. Today is a special ATP Hour because we once in a while we have session for just taking question and answer. I know I've been doing a lot of talking on my own, talking about different child health topics, asthma, malaria. We've had so many different topics so far. So today is an opportunity for you to do a question and answer live session with me. So I'm live in the studio and you can ask any questions you have on your children health issues, depending on whichever platform you're watching from. For those of you watching on Instagram or Facebook, you are free to drop your question directly under the video, whether the Facebook page or Ask the Pediatrician's Facebook page, or on Instagram. However, for those of you who maybe are listening on the radio and you don't have opportunity to type in, you can send a WhatsApp message of your question to, I think, the Fresh Race Radio WhatsApp number. I don't know whether Esther will display that for you later or tell us on how they can send for the radio audience. However, for those of you who are on Instagram, Facebook, YouTube, you're free to drop your questions on any child health issues. And in the next 1 hour, I will try my best to answer them. And please try and help us to share the video. I'm also going to do the same. Share the video on whichever page you're watching. Invite your friends, invite your family. Let's just share it so that many people can watch and many people can join us. So I'm also going to do that in the next 1 minute or so. So, but while I'm doing that, please start to drop your questions on any platform where you are. Or if you are listening live on radio, please uh, try and send in your question on any way you can send it on the WhatsApp for Fresh Race Radio. So thank you so much, Esther, for having me. It's a pleasure to be here.
Yeah, it's always a pleasure to have you, ma. Yeah.
So I'm just trying to share the links to all our platforms, making sure everybody can see and you can hear. And I think I've done that. And I'll just try and make sure that we have pinned them and people can watch it live. All right. So we'll be starting in another couple of minutes. Remember to drop your questions and we will try and take them. I don't know whether we've had any question coming during the before now because I always tell people to send their questions in and we'll try and answer them in future episodes. So this is an opportunity for us to do that in case you've had any questions over the weeks and months before now. Just to remind those who are watching on Ask the Pediatrician Facebook group, because this is live on our page, not on our group, you won't be able to drop your question directly under the video. You have to click on the video, get to the page, and then you'll be able to drop your questions. So that's the only way we'll be able to answer that question. All right. So, because I can see some of you are already dropping comments, but you have to make sure you go to the page and that way we can see your question in the studio. Okay, we already have some questions coming in, Esther. Okay, thank you, Nika, for joining us. Uh, good morning to you as well. Okay, let's go on. Esther, do you want to read the question so that then?
Okay, so we are from Jemima. Thank you. Good morning, Jemima. And she's asking, how frequent should a toddler poop in a day? Is it normal for a toddler to poop thrice times a day?
All right. Thank you so much, Jemima. That's a very lovely question. So the question, for just to clarify, how many times, what is normal in terms of the frequency of passing stools a day? And actually that question, there is actually no um, frequency that is abnormal. That's the honest truth. In other words, babies can pass stools as many times as they want a day. Um, though most people maybe will do it once or twice, but what really matters for us is the texture of the stools. It is not the number of how many times the child passes stools that bothers us. It is the texture of the stool that is passed. So if your child is passing normal stool, I think I have a picture of the stool chart somewhere on this platform. I hope I've not deleted it. If I've not deleted it, I will show you. Okay, I think I have it. Yeah. So for if you're watching on YouTube, you'll be able to see that. So there are different texture of stool. We have a stool chart. So the type 4 is actually what we call normal stool. Let me remove that question so that people can see that chart. So the type 4 is like a sausage, soft stool. That is normal stool. So if your baby is passing that kind of normal stool, no matter how many times the baby passes in a day, that is fine. All right. So passing 3 times, 4 times, once, or even not every day is fine. Every child has their own bowel pattern, and with time, and though it can also change from time to time, but as long as the stools are normal, it is not a problem. However, if your child passes watery stools, like watery, if you look at my stool chart, that would be type 5 or type 7, like watery, like like liquid, like urine is flowing, then that is diarrhea. So if your child passes that kind of watery stool 3 times or more in a day, we will call it diarrhea, and that is not normal, and that requires treatment with ORS and oral sink and all that. There's some children don't pass too frequently. Some children may not pass their stool every day. Some pass to maybe once every other day. Some may not pass it once every 3 days. That is their normal bowel pattern. As long as the stool, whenever they pass it, is still soft stool, like type 4, then that is fine. But if your child is passing hard stool, like type 1 to 3, where it is like comb, like comb of a corn, or like it is very lumpy, or it's coming out in droplet like rabbits, rabbit droppings, that is constipation. If your baby is not passing the stool frequently, and it's when they are passing it is very hard, you can see the child is in agony, they're struggling to pass the stool, then that is constipation. So if your baby is not constipated, or if the child is not having diarrhea, it doesn't really matter how many times the child passes stool, that is still normal. So, and each child have their own different stool or bowel movement pattern, so which is absolutely fine. So I hope that question helps you, Jemima. All right, we're going to move on. I have a question on Instagram. So let me take that question on Instagram. Kick say good morning. My son is 27 months old. His fontanelle hasn't closed yet. You can still see it pulsating. Also, he hasn't started talking. He babbles a lot, but not understandable yet. Okay, thank you, Kicks, for joining us this morning. I hope you're still listening. So let's take the first part of your question, your child's fontanelle. So there's what we call the anterior fontanelle, which is like a hole or a space in the skull bone. Now, the hole is there because baby's brain are still growing. 95% of the brain growth in children occurs in the first 5 years of life. So because their brain are still growing, we need those spaces in the skull, in that bone, that we call the skull, so that it can accommodate the growing brain, so it doesn't squish it. It has to move apart. And so most anterior fontanelle will close by the age of 18 months to 24 months. However, for some children, for several reasons, it may not close immediately. It depends on how open it is. Is it something that can take a tip of your finger, or is it something really, really very obviously open, like the newborn period? So if it's just a tiny space or something, there's nothing to worry about. The pulsation is not what we're worried about. The pulsation does not mean the fontanelle is still open. The pulsation is a blood vessel. The blood vessel will always be there. So a lot of parents always think, oh, the place breathing is pulsating. It is not the anterior fontanelle that is pulsating. It's not the anterior fontanelle that is breathing in codes. It is the blood vessels that are there, and those blood vessels, especially the arteries, they will always be there and they will always pulsate. So what we are interested in is that a hole in there that can take your finger, a tip of your finger, a whole finger, 2 fingers. It is that hole that is the anterior fontanelle, not the pulsation, not that. So that is what you really need to tell us. So is there a real hole there? And if this hole is there, what can it take? How much of your finger can it take? So if it can take more than a tip of your finger, then that is really wide. And then that you need to see a pediatrician, not because we are worried so much, but we want to make sure that the causes of what we call delayed closure of the anterior fontanelle, we need to look at it, especially in a child that you're also concerned about developmental delay, because if your 2-year-old is not talking at all, that child is delayed. Okay, a 2-year-old should be talking. A 2-year-old should be combining at least 2 words together. Should be saying at least up to 50 single words and even more. So if your 2-year-old has absolutely no words and is only babbling, that child has speech delay. That child needs to see a speech therapist first. So the speech therapist may do an assessment and may give you some therapy exercises and things you can do to encourage the child's talking. And if there are other issues, because sometimes parents are looking at the children talking, but there are other things that professionals we're looking at. We're looking at whether the child is the child playing? Is the child interacting with other children? Because before you start to talk, you must learn what we call pretend play or symbolic play, because language is actually a symbolic thing. So when I say dog, what you'd see is a picture of a dog in your mind. You don't see DOG. DOG is what we all have agreed in English language to use to represent that 4-legged animals, the back. All right. So for a child to be able to understand language, that child must be able to understand what we call pretend play. Must know that so I can take a pencil and use it like a microphone. That is pretending, and that is symbolic, that kind of a thing. So the speech therapists, they assess for all those things. We're looking at the child eye contact. We're looking at what we call social reciprocity, interaction back and forth. So that child needs to have an assessment. If the speech therapist think there is more than just the child not talking, okay, because the child can just be a little bit slower, which is fine, but the child may also have other issues like autism spectrum disorder. So the pediatrician, the speech therapist may refer the child to see a pediatrician who will now do further developmental assessment. So whichever way your child needs to see a speech therapist for the speech delay, the child needs to see a pediatrician for the delay fontanelle, and if there's other reason why the child may have developmental delay. So I hope that is helpful for Jim Hike. All right, thank you. Before we go back to Facebook, I'll take the second question on Instagram. Queen of Hearts say, good morning. Please, my son is 6 months plus, but has a stubborn rash around the anus and it bothers me. I was told it's jetty. I don't know. If your child has a rash around the anus, please see a pediatrician. Don't take advice from people that everything is jetty to them and all that. No, a 6 month old should never have rashes around the anus. Okay, we need to look at the rashes, and when we look at the rashes, then we can decide what is the cause of the rash. It could be something as simple as a nappy rash, because you need to make sure you are changing your baby's nappy frequently. You wash the bottom, and some children react to some of these wipes that we use. So sometimes you may just want to use water and all that. So, and you should not wait until the diaper is almost falling out before you change it. Once it is wet or once it is soiled, you must change it immediately. And then apply nappy cream around the area, things like pseudo cream and all that. So you need to make sure you are doing all that correctly first. And also some food that some of you give your baby. If your baby is not your baby 6 months plus, if you say give formula or some other food, sometimes some children react to some of those products and they can have it can come out, it can affect their stool, it may make him a little bit more acidic, and then it can have rashes as well. So these are all things that a doctor will be asking you to know which one is causing this rash, and then we'll be able to treat it. Oh, your child can even have infections. You can have bacterial infection, you can have fungal infection around the nappy area as well. So we need to know, is it a fungal infection? Do we need to give antifungal product? So don't just say everything is jetty, okay? People use the word jadi a lot in Nigerian, and they use it to mean different things, from back pain to cough to skin rash to rectal prolapse or hemorrhoids and all that. When I did a survey on Ask the Pediatrician Foundation group, and I asked people to describe to me in English what exactly they meant when they use the word jadi, and I actually wrote an article on it on our website, which you can always check out. I got over 20 different medical conditions. Okay, so in other words, when people use the word jadi, to different people it means different things, and we got over 20. So for some people it just means dysentery, like blood in the stool. For some people, it's rectal prolapse when, like the anus is coming out. For some people, it is hemorrhoids when something is always outside of the anus. For some people, it is rash. Even people say cough. Even people say different things, and it is all jadi. So it's a word that I personally don't think we should even be using at all when you are asking questions on this kind of platform. Or rather, you just tell us what is wrong with your child instead of saying jadi. No, people use that word to mean different things. But for what you say your child has a skin rash around the anus, that child needs to see a doctor and then let them tell you what is the cause of the rash and then the appropriate treatment. Avoid taking diagnosis from people who don't know better. So because they will always tell you one thing or the other. All right, so I hope Queen of Hearts were still listening, and I hope you got the answer to that. Thank you. All right, so we can come back to our Facebook now. We have a question here. Okay, there's no question.
Top of the morning.
Okay, there's no question.
Our children's lives. Thank you. Oh, thank you, Mrs. Chinenye. Thank you so much for that.
Thank you.
Okay, she has a question, and she's saying that I know a 3 months baby girl, her elbow, her knee joints are stiff. I have to apply light pressure to cool her legs and.
Okay, I don't know why we're having so much background noise on your hand, Hester. Okay, thank you for reading the question. So, Emiagi Chinaye Adaigwe, thank you so much for that compliment. I really, really appreciate your kind words. So a 3-month-old baby whose elbow and knee joints are safe, a baby should never be safe. A 3-month-old should not be safe. So if you are having to apply pressure to pull the legs and the hands of a 3-month-old, I am very worried about that child. That child most likely may be developing what we call cerebral palsy. I think I've taken a topic on cerebral palsy recently. I can't remember, but it's something I'm sure we've done before, or we've written about it on our website. So you definitely need to take that child to see a pediatrician. All right. When babies are born, they are flexed, but they're not flex to the point that you have to. And usually when they sleep, they kind of relaxes their body, so they shouldn't be stiff like you need to be stretching. Now, does your child has like neck control? Can your child hold the neck, which is what we expect a 3 month old to be doing? So if the child cannot hold the neck and the child is also very stiff and all that, then that child may have a neurological problem. There may be something, usually if I'm seeing this child, I'm going to be asking you a lot of questions. What happened during the pregnancy? What happened during the delivery? Did the child cry when the baby was born? Did the child have jaundice that was severe, that was not properly managed? Did the child have any infection in the newborn period, like meningitis? Something must have happened to this child either in the womb or during the process of delivery or shortly after the delivery that may have caused some kind of injury in the brain. And that is why this child is developing this stiffness of the body, because usually our brain controls what we do with our hands and legs and stuff. So if there's any injury in the brain, it may make the child to have that stiffness. So this child, as a priority, as a form of urgency, needs to see a pediatrician, and then they can tell you what to do. We usually would do a lot more investigation to know the cause, and then we'll be able to start treatment. The child may need things like physiotherapy and all that. So this child, you really need to see the pediatrician as fast as possible. So I hope that is helpful, Chineye. Thank you so much for listening. All right, let's go on to the next question.
Good morning, doctors. Please, how do one prepare nasal drop for kids? It's hard to see in most pharmacies, and can a child of 4 years use it for decongestion of the nose when there is catarrh?
All right. Thank you, Julius, Fejiro, Colleen, for joining us this morning. Thank you for that question. So let's start by saying that we don't expect you to be using nasal drops for every child who has catarrh. Okay, it's very, very important that I stress and explain that. So because a lot of mothers go to the shops when the child has catarrh, they want to buy something to drop in the nose. It is not absolutely not necessary to drop anything in the nose if your child has catarrh. If your child has catarrh or nasal congestion, whatever you call it, and it is flowing out, whatever, you can see the liquid coming out of the nose, then that child does not need any nasal drop. Okay. The only time we put something in, and usually for the older children, they can sneeze. Okay, they can sneeze and clear their nose by themselves. So as long as the child can sneeze and clear their nose, there's no need for nasal drop. And as long as their nose is flowing, the catarrh is flowing, there's no need for any nasal drop. Now, the people that we tend to give nasal drops, they are the babies. Number one, because they cannot sneeze. Okay. And when the catarrh, not that they cannot sneeze, but they cannot do it conscious. Like you can't just tell baby has sneeze and baby will respond to that. But usually you can tell the older children to do it. But if there's, and usually we only give it to them if there is the catarrh is thick and hard, and it's not flowing out and it's blocking the nose. In other words, babies' nose are very, really tiny, and babies always breathe through their nose. They don't breathe through their mouth like adults. We can breathe through your nose, you can breathe through your mouth. So because babies are what we call obligate nasal breathers, in other words, they always have to breathe through their nose, and they have these tiny noses with tiny holes inside. Any little catarrh that is thick, that cannot flow out, blocking that nose, they will struggle to breathe. They'll start having difficulty with breathing. Okay. And so that is why we apply those nasal drops. Like usually what we give them is saline. Saline is salt, the normal table salt you use to cook your food, dissolve in water. That is it. And what we're doing, that we're putting that to soften the mucus, so that the mucus can flow out and the baby can breathe. All we're trying to do is to clear that nostrils of any block, debris or block catarrh that is not flowing out and that is blocking the small hole of nose, and that is making the baby find it difficult to breathe. So that is all we're trying to do. All right. So if your baby's nose is flowing, nothing is blocking the nose, there's no need for any nasal drop. The nasal drop is not the treatment for the infection. It is not. It's not doing any magic. It's not going to make the catarrh go away. Most of those catarrh, cough, and all that, they are what we call viral infections. So they will run their own course and they will stop by themselves. So we don't treat them with drugs. So we're only supporting that child breathing if the catarrh is thick and it's blocking the nose. So we put a drops there to soften it and to flow out. It is easier for babies when you do that for them. For a child who is old enough to sneeze out, you can ask them, yeah, blow your nose, and they can blow their nose, and the nose is not blocked or nothing. There's really no need to put nasal drops. And please, when you go to pharmacy and you ask for saline drops, because unfortunately in Nigeria, not all our pharmacies are manned by trained pharmacists or health professionals. Some of our pharmacies are manned by salespeople, market people who don't know nothing about what you are drawing. So sometimes you go to them and tell them, I need saline nasal drop, but because they don't have saline nasal drop, and then they must set their markets. So they will just give you any nasal drop. So I see a lot of people using what's the name of the one they tend to buy? I've forgotten the name, I'll remember later. And the Otravin nasal drop. Otravin nasal drop is a steroid, and it's not meant to be used routinely. It is meant to be used only when prescribed by doctor. Usually the ENT doctor prescribe it usually for children who have what we call allergic rhinitis. So some people, when you go to pharmacy and the pharmacists don't have the saline, which is salt and water nasal drops, then they give them Otravin. And most time the people are like, I was like, I'm horrified, and obviously, thank God for at least most mothers are now reading leaflets of medications, and then they will see that, oh, this is not right. You should not use this medication for babies less than 2 years, and they will always ask us. So that is how we always know that they're giving them the wrong thing. So please don't use that. So if they don't have the saline drops, I don't have a picture here now that I've shown you. It looks like a small drop, but please, it is very important. This is why female education is important. Mothers should be able to read. When you go to pharmacy, you say you have one saline drop, normal saline drops. If you see anything written on that drops that is not normal saline, please do not buy it. Do not use it, okay? If they give you Otravin or any other drop and you see that the name written on it, the name will always be written on it. It's not normal saline. Please don't even be asking, is it the same thing as normal saline? It is not. If it is saline drop, there's no other name that will be written on it beyond normal saline. So you should take you should drop it back for them. You can ask them to actually give you the normal saline drip, the big one that we normally use to give people when they have drip. It's the same thing that is inside. It's just that one, it's just that when you buy that one, you're going to waste majority of it, and then to keep it and to cover it's always a challenge. But that is the next best thing you can buy. Or don't need to, just leave it alone. But the saline drops is the same normal saline inside both of them, but that one has been packaged in a smaller container so that and then you can press and drop it, and it's just one drop in each of the nostrils for like 3 times a day. It's just to soften the mucus. It's not meant to do any magic. So don't expect that if you don't buy it, as long as your baby's nose is not blocked on the nose. Sometimes if you are really struggling, your baby is really struggling to breathe, we may need to nebulize the baby who like those who are having asthma, we'll give them something to breathe through, like we make it into like steam or something so that it will soften it. That's another thing people do, but I usually don't want to recommend steam inhalation for babies because hot water, a lot of mothers will pour hot water on their babies in that process because they are so, it requires a lot of being very organized and being practical. Otherwise, you're going to pour hot water on, and that is more dangerous than having nose blocked. So, but if you can get the saline drops, if you go to big pharmacies, there we have it. Okay, I think that is just what I would say. But for 4-year-olds, if the 4-year-old can blow their nose, they don't need any drops at all. All right, thank you. I don't think we have any question again on Instagram. So if you have any questions still, please ask your questions and we will. Okay, I think Julia's Reggie is responding. Okay, so Jesus Radio is saying thank you for your response. This congestion always happen when it's sleeping. During the day it comes out, but at night I feel the nose is blocked stomach. Now you need to also understand one thing: it's not all blocked nose or congestion that is due to mucus. So when I say apply saline drops, it is for if it is blocked with mucus. So some children don't have their noses blocked with mucus, but their noses are blocked for other reasons. So either there's blood flowing. So usually that happens for children who are having allergies, especially allergic rhinitis. So if your child is having those kind of recurrent nose blocking, especially at night, it is a possibility that your child is having allergic, especially if it's something that's been going on for years and months. It is very likely that your child has what we call allergic rhinitis. And so what you need to do is to take that child to see a pediatrician or ENT doctors. They are the ones that manage such cases. And they are the one that is when sometimes they may prescribe steroid sprays. There's a different kind of sprays we used to manage those kind of children. So, but then it has to be prescribed because they all have side effects. So before doctors give you drugs, they need to know and they need to educate you about the side effects to watch out for, how long you're supposed to use it for, and all that. So it's very important that it's not something you self administer or self medicate. It's not something you can just use by yourself. A doctor has to prescribe it, and the doctor has to monitor your child when the child is on that medication. And sometimes, some children have this thing as a seasonal thing. So sometimes we use it during a particular season, and when the season is over and the children are much better, we will stop the medication. So there are many ways, for such kind of management. So don't just use any sprays or anything else, and don't just assume every nasal congestion is mucus blocking your baby's nose. There may be no mucus, so it's better you see the doctors, and then preferably the ENT doctor. It's really something that's been going on for too long, and then they will take it up from there. Thank you so much for asking. All right. Okay, sorry. EM Ike is saying that was, sorry, going back to Instagram. EM Ike is the one that has question about the anterior fontanelle that is open, and he's saying that the anterior fontanelle is about 2 cm wide. So 2 cm is a lot. If it is 2 cm wide, that is really wide. So I really want you to see a pediatrician. There are causes of enlarged fontanelle. So we have things like hypothyroidism and all that. So and some of them are treatable, like hypothyroidism, for example, we can treat it. So it is better you see the pediatrician. I just saw that you gave a feedback on that. I didn't notice on time. So you definitely 2 cm is wide for a 2-year-old. You need to see a pediatrician, and then they will investigate. It just sometimes we may do nothing if we didn't find anything. But if we just to make sure we're not missing out all the causes of such situation in children, and I think that is the most important thing. All right, thanks a lot. Okay, so please drop your questions. I don't know whether we have any questions coming out from any other angle. Esther?
No, we don't for now.
Oh, okay. All right. I'm just checking that we don't have any on our other Facebook groups as well. No, okay. I don't think we have any on Instagram for now as well. Okay, so we don't have any questions for now. This is an opportunity to ask your questions. Okay, yeah, there are no questions for now. All right. So, for those of you who are just joining us, welcome to Ask the Pediatrician Hour. Today is a live broadcast, and we're just taking question and answers that you may have about the health of your children. Usually, I do a teaching on Thursdays, and I take a particular topic. And if you've mixed any of those old presentations or broadcasts, you can still listen to them. If you go to, there are many platforms in which you can watch them. You can watch them on Ask the Pediatricians Foundation Facebook page. The videos are always there. They're never going to go away. So just scroll back, look through all our videos, and you can watch them. In the last 2 weeks, I think we did something on asthma last week. And the week before, we did a malaria update. And somebody was asking me a question yesterday about malaria vaccine. Oh, that's how come with all the technology, our doctors, scientists have not produced vaccine. And I was surprised because I just did a podcast and a broadcast giving malaria updates. We actually now have the malaria vaccine, and it's going to be available very soon in Nigeria. We're going to be giving these vaccines to children between the ages of 3 months to 36 months. Okay, so watch out. Once you hear it is available in your health center and your baby is between 0 to 3, 3 months to 3 years, you have to take your child to the health center to get the malaria vaccine. And a lot of people were asking, why are we giving only the children the malaria vaccine? After all of us have malaria, and especially those of us who live in Nigeria and sub-Saharan Africa, where malaria is endemic. Okay, and I've explained that 80%, or let's just say more than almost 90% of all deaths of people from malaria is in children below the age of 5. So it is the children that are dying from malaria. They are the ones that tend to have what we call severe malaria, and those are the type of malaria that will kill the children. So the children are the ones that are likely to die from malaria, and because children are the ones likely to die from malaria, so it is obvious that we have to prioritize the children now that the vaccine is available. So malaria vaccine is going to be given to the children first, because they are the one likely to die from malaria. Most of you, you have malaria, you are still going to work. You have malaria, you are okay, nothing. I mean, it's because you already developed what we call partial immunity against malaria. But children below the age of 5, pregnant women, people coming from outside Nigeria or outside malaria, those who live in countries where there's no malaria, when they get exposed to malaria, they have what we call severe kind of malaria, and those are the ones that are likely going to die from malaria. So the vaccines are going to prioritize for those who are likely to die from malaria rather than for everybody. So in a few weeks or months, hopefully, the immunization for malaria will be available for the children less than 3. Okay, and you need to make sure that you get. So that's just an example of things that we have discussed before, but maybe you missed them. You can always watch them on our Facebook page. Also, you can watch them on Fresh Waves Radio Facebook page as well, or you can listen to them on my podcast. You can actually watch and listen as well, because some of the podcasts are video podcasts on any of the podcast platforms. So we have what we call Spotify, and we have the Google Podcasts and Amazon Music, and so many other podcasts. Once you just Google Ask Dr. Bemi ATP, you can get that podcast and you can ask your questions. I mean, you can listen to the and watch the broadcast, and you can learn. So we've talked about so many topics that have to do with the health of our children. Just an opportunity for you to watch them and to learn. And if you're the type that like reading, you can go to our website. So it's www.askthepediatricians.com, and you can also read about all these important topics like immunization, teething, so many things that you really want to know about the health of your children. Even for those of you who are first-time mothers, there are lots of materials I have for first-time mothers on First Time Mom Companion, just to help you navigate motherhood without tears, you know. So and you can become calm and confident as a mom. So these are all things you can access for free, and you can keep learning, because like we always say, our vision is to make sure that no child in Africa, in fact all over the world, dies from preventable things. So that is why we do all this health education and information podcasts. I hope that will be helpful. All right, let's go. I think we have another question from Chineye. Yeah.
Okay. Thanks for your kind response. And concerning the 3-month-old baby that sees a new hand elbow joint stiff, the baby holds her head, stands on her own with support. She's sleeping now, but the joints are not stiff.
Okay, yeah, it's good that I'm happy to hear that the joints are not still when baby is sleeping, but I'm still worried about this baby, because you said this baby like to stand on her own. A 3 months old should not be standing at all. A 3 months old should not be standing. So if a 3 months old is standing, I'm worried. Again, it boils down to the fact that that child is safe. Okay, because when they are safe, they want to be in an upright posture rather than sit. It's a 3 month old opening the neck, that is good, but they should not be standing and they should not be stiff when they are awake. So I'm not sure what is really going on with this baby. So again, I think it's better we see the child first. So sometimes parents try to describe things and you are trying your best, but it's possible maybe you're not using the right words. So I don't want to assume too much. So but then if you are worried enough to ask this question and you're worried enough that your baby is somehow safe during the daytime, I think it's I would just be on the I will err on the side of caution and say, let one of my colleagues, a pediatrician, have a look at the baby. If the pediatrician have a look at the baby and the pediatrician say, oh, the baby is fine and they are not worried, then I think that is more reassuring than for us to assume there's nothing wrong, and then we we are late in starting things. So because sometimes early intervention always is better and it works. So we prefer to identify if a child is having difficulties early, and we prefer to deal with it earlier as well. So it's good to know that the baby is having air control and baby is not stiff while sleeping, but the baby should also not be stiff while awake. Okay, so I will recommend you see, just have a pediatrician give you an opinion, and whatever they say, that's fine. If they say there's no problem, absolutely. If they say there is, then they will tell you what to do in terms of intervention. All right, so that's that. So if you have any questions, feel free to ask your questions and then we'll try and answer them. So I was just doing some announcements, and I said that if you want to learn more about health issues, feel free to post on our Facebook group. Um, okay, I think something is. Okay, thank you, Chinaya. We really appreciate you joining us. All right. So going forward, concerning some tips, I would just like to give some tips to parents, because yesterday I saw a mom who posted on our Facebook group that her baby has like a little boil on the face and she popped it, and then the things are getting bigger and all that. And I asked her to take the child to the hospital, and because of that, I put up a message that just to alert parents that please, the face area is very, very important and very sensitive. Avoid popping anything on your baby's face. If they have a little boil or something, please don't press, don't pop it, don't pop pimples, don't, especially what we call the dangerous area. There's a triangle area from your nose down to the tip of your mouth. Those areas, we call them the dangerous area of the face. And why do we call them the dangerous area of the face? Is that any infection in those areas, they go straight to the brain. Okay, because the blood vessels that are there, the way they drain, the blood vessels are going to your brain. So if you have like a pimples or infection, some of you just start pressing, popping, you are going to introduce germs, and that germs will go into the blood vessels and they're going into the brain of the child or even the adults. And this can cause what we call infection in the brain. Infection of the brain are one of the most dangerous infections to have. So you don't want children having infection in their brain, because number one, we can lose them. They can have meningitis, they can have encephalitis, they can have abscess in the brain. Number one, the child can die from the process. Number two, if we're able to manage to save the child can develop what we call lifelong disabilities, the cerebral palsy and co. So we don't want anything touching the brain at all. So please and please, just to remind those of you who are listening now, don't pop anything on your face. Just make it an habit. Don't pop things. I know some say, oh, there's a dangerous area, but some of you will not remember where the dangerous area is. So just to be on the safe side, don't pop anything on the face. There's a pimple, there's a boil. Just avoid that, okay? There are other ways by which you can get rid of them without pressing and popping and all that. So I'll leave that just as a tip. Okay, I think we have a few questions popping in on Instagram, so I'll just take them now. Amus Olaun, excuse me, Amus Olaun says, is there any quantity of water a baby of 15 months should take? Yes, there is. So we calculate the amount of water everybody should take a day based on the weight. So your 15-month-old baby, just a year old, most likely weighs averagely 10 kilos. And usually that means they should take 100 mils per kilos for the first 10 kilos. And that is what we call 1 liter. So your baby should just take about 1 liter of water in a day. But remember, that water is not just the plain water. It includes the milk, includes the tea, includes everything liquid that your child is taking. So luckily, the body regulates how much water you take. So normally you feel thirsty if the water level is low. So children will feel thirsty, they will ask you for more water to drink. So the body has what we call receptors or agents, just let's just put it that way, that help you to know whether the amount of water in the body is fine or not. If it is becoming low, that is when you start feeling like, oh, I need to go drink water. So that is your body's receptors telling you your body water is low. But just to be on the safe side, it's good to know how much quantity, in case some children don't like drinking water and we don't want them dehydrated. So 1 liter, including all the water in the pap, in the tea, in every other liquid that the child takes in a day, will be fine. And of course, if you take too much water, your body will excrete it in urine. So there is no need to panic. Oh, is my baby not taking enough? Is my baby taking too much? Because the body has its own mechanism for regulating that. If you are not taking enough, the body will make the child thirsty. The child will want to drink water. If you are taking too much, the child is going to go to toilet a lot more and pass out the excess. So you don't need to worry or panic about that. But it's always good to make sure they have enough water in their body. So yeah, it's okay. Say like how many liter? Just 1 liter for a 15-month-old. Bukola Ogunmola, is there any pediatrician to see around Mowe or Father Ogun State? Of course, I'm sure there are pediatricians everywhere. There are pediatricians in Ogun State. Unfortunately, I'm not able to recommend like any specific pediatrician, for example. But I will just say, if you go to the government hospital close by around your area, maybe a general hospital, I don't know whether you have one, or a teaching hospital, then you can. Mowe is not too far from Lagos, to be honest. So I'm sure they have a state hospital around somewhere around there. So just go. So you're likely going to meet pediatricians in the general and teaching hospital. You're not going to meet them in the health center. Some of you will say, I want to go to the health center. Can I see? You're not going to see pediatricians in health centers. Pediatricians don't work at health centers. So health center is like the first level of care, and it's more of prevention. They should give you immunization. They should give you family planning and all those kind of what we call preventive or promotive kind of healthcare. But once a child is starting to get sick and needs treatment, it's no longer health center level. Those are actually at the what we call the secondary level of care, or general hospitals or state hospitals, or tertiary level of care, like the teaching hospitals, the federal medical centers. And you are likely going to find pediatricians at those secondary or tertiary level of care. Of course, there will also be pediatricians in private practice. So you can always ask, and please always be sure, because some people think every doctor who sees a child is a pediatrician. No, there are many doctors who can see a child who are not pediatricians. So it is not every case we want the pediatrician to see as well. So if it will be so overwhelmed, I think we have just about 1,000 pediatricians in the whole of Nigeria, and that is to about I don't know how many. Our children are about 50% of the population. So if our population is about 200 million, then that means we have close to 100 million people who need pediatricians. So, and we have just 1,000, and many people are still living every day. So we cannot definitely see all the children. So there are simple cases, the general doctors, the medical officers, the family physicians will see. So, but it is only very special cases, things that are more serious or that are more complex that pediatrician have to see. So if you are not sure, it is okay to see any doctor first, and the doctor can now tell you, okay, go see the pediatrician if they have if they think there is more. All right. Okay, seem like only Instagram people are on fire now. All right, let's go on to the next question on Instagram. Iberi Joanna saying, good morning, ma. Please, is symbiotic and antibiotics? I'm not sure I really understand your question. Okay, but you're asking whether a particular product is an antibiotic. I was given last year when my son was sick. I want to know if it's like zinc or antibiotic. Unfortunately, I'm not familiar with that particular trade name. So, but it's not difficult to know what is inside a drug. So the big name that you see written on the package of any product is a trade name. So, for example, you will see Avipol. Avipol is a brand of paracetamol. Or you can see MCAP. MCAP is a brand of paracetamol. So, but below that MCAP, below the Avipol, they will always write the real drug name inside. Okay, so they will write, if they write Avipol on the top, then they will write paracetamol underneath it. If they write MCAP, they will write paracetamol. So when you look at the products, look at the big name, that is the trade name. Look at what they wrote in tiny, smaller fonts below it, or look at the side of the product. They will write, this product contains this. So look at what is written there. Read the leaflet in the medication. Okay, the leaflet in the medication will tell you what the product is meant for. It will tell you this is an antibiotic for the treatment of infection. It should be prescribed by your doctors, or it will tell you this is oral zinc. So it is very easy to know what is in the product because it is always written. There are laws that say it must be written. The original, what we call generic name of the drug will be written below it. It will be written under this product contain. And even for food, most of you don't know that whenever you buy anything, what is inside is always written on them. So it's always good for you to always read first before you start using them. So you read first. And I find it very difficult that you've been prescribed a drug many years, like a year ago, and you don't even know what it's meant for. That is a very dangerous thing to do, honestly. And I want you to take better responsibility. Whenever a doctor gives you a product, they must tell you what that product is meant to do. What is the role? We are no longer in the era of they just give you anything in the hospital and you also just take it by blind faith and you just go home and use it. No, we are no longer in that era at all. So whenever a doctor, it's the responsibility of that doctor to explain to you, this is the drug I'm giving to you. This drug is meant to do A, B, C. These are the side effects to check to get from these drugs. If your child have these side effects XYZ, please stop the drugs and come and see me. Okay, you must always ask those questions every time they give you any medication. What is this drug meant to do? Sometimes people give you medication, you think that they are treating a particular condition. No, we may not be treating that condition with that drug. The drug may be supposed to do something else different. For example, let me use the diarrhea instances. If you raise or oral sync for diarrhea, the goal of those drugs is not to stop the diarrhea, because a lot of mother will always ask me, "Oh, doctor, I went to the hospital and they gave me ORS and oral sync, and now my child is still having diarrhea," and I'm like, and so because the drug is not meant to stop the diarrhea. A lot of mother go, they might stop the stooling. No, the doctor is not stopping the stooling. We want to rehydrate the child. We want to heal the intestine. That's what those drugs are meant to do. So the stooling, we expect it to stop by itself. So giving ORS, it will not stop the stool. The stool, we don't want the child to get dehydrated. Important that you understand what drugs are meant to do and from those, and what side effects to watch out for, when to stop them, and all that. These are information that are so important. Our time is gone, but maybe another time I will get an pharmacist to come and we can talk about this aspect, because I see that a lot of us, we just take drugs blindly. And please make sure you read the leaflets. That is why we talk about female education. It's so important to child health. It's so important to child survival. You must be able to read. And the essence of you going to school, essence of you going to all these things, so that when you get things like drugs, you have a leaflet. Please read it first before you start using the drugs. Know what it's meant to do, even the side effects, whether pregnant women should use it or not, whether nursing mother. These are important information, and that is the value of our education, so that we can read for ourselves. Most of those things are written in simple language that anybody, even primary 4 children, will be able to read them and understand. So it's so important for you to do this. Unfortunately, I'm not able to help you this time around because I'm not familiar with that particular brand name, but you can also Google it. If you put the brand name and Google it, they will tell you what, because different countries, so many, you can imagine paracetamol, we have like thousands and thousands of companies making paracetamol. So until we read it, we won't know which, that everybody has their own name for it. So, but if you Google it or if you go read in the leaflets, then you'll be sure. All right, let's take the final question before we go out the hair. Amus say, I've seen pediatrician prescribe cough syrup for babies like 1 year plus. Why some pediatrician will tell you cough syrup is not for babies? Is there implication and all that? Okay, so the short answer to it is that we don't recommend cough syrup for babies. And the reason, you see, it's more important to understand why some things are not done. All right, number one, just like I was just explaining for diarrhea now, the problem is not the cough. Cough is actually good. Cough is a reflex. Cough is the body trying to get rid of that foreign product or whatever is irritating the throat. So the cough is not the problem here. What is causing the cough is what we need to be addressing. Is this child having pneumonia? Is this child having a bacteria? Maybe the child is having a heart problem. So when the child has cough, we want to address the underlying cause rather than dealing with the cough. Unfortunately, some mothers will give cough syrup and then they will relax and think that, okay, all is well, when all is not well. This is the reason why majority of our children are still dying for pneumonia, because children who have cough, fever, people give them cough syrup rather than take them to the hospital. The cough syrup is not going to treat your child. It is the antibiotics to treat the pneumonia that is more important for that child to take. When we treat the pneumonia or whatever is causing the cough will go away. So the cough is not our problem here. We only treat cough if it is really, really very bad and it's distressing the child. And the child is coughing to the point that they are very distressed. So sometimes they can give something to calm them down or that. But more importantly is the treatment of the underlying cause of the cough. And so we want mothers not to relax because they've given cough syrup. We want you to go to the hospital to see the pediatrician first. Let them decide what is causing the cough, and then they can treat the underlying cause. Okay. So if the pediatrician is treating the underlying cause and you now feel that, okay, the cough is so distressing, I want to give something to kind of relieve it a bit, that is still okay, because the pediatrician is the one treating this child, is already addressing the underlying cause. But we don't want you mothers sitting at home giving your child cough syrup thinking the problem is over while that child is dying of pneumonia. Two, some of these cough syrup are sedative, so they kind of reduce breathing. Children are what is important for children is that they must always breathe. When a child is not breathing, they begin to die, unlike adults who most of the time is a cardiac problem first. For children, is a respiratory failure first. So we don't want anything that slows down the breathing of children. That is what most of the cough syrup does. So they slow down the breathing, they slow down the coughing. This child is having a very severe respiratory infection. This child needs to be breathing, or otherwise they are not getting oxygen in their body, then that child is very close to dying. Okay, so this is why we don't want them to be on cough syrup. So the focus is not the cough syrup. It's just like taking paracetamol when you have malaria. The paracetamol will reduce your fever, but it's not treating your malaria. You still need to take your anti-malaria, and no matter how much paracetamol you take, the malaria is not going to go away until you treat the malaria. The same thing for cough. No matter how much cough syrup you give your children, until you treat the underlying cause of the cough, the child is not going to get better. And for children, they can die very fast from pneumonia, from things like that. So we don't want you wasting time thinking you are treating cough when you are giving them cough syrup. We want you to take them to the hospital. Let the doctors see them. Let them prescribe the appropriate treatment for the underlying cause, and then then all the other side effects of cough syrup, again, the slowing down of breathing and all those sedative effects, we don't want it in children. So for children, especially for infants who cannot talk, for preverbal children who cannot talk, children who cannot tell you that, so this is what is going on with me, you don't want to give them anything that will sedate them. You don't want to give them cough syrup. Helpful. My time is gone. I think I have to leave the studio now so that Frederick can continue. So thank you so much for watching, and hopefully another time we'll have time, another once in a blue moon again, we'll come back again to have our live question and answer. But before then, we'll keep on having the teaching session. So thank you so much for having me, and have a wonderful, wonderful day. Bye. Bye.
All right, thanks very much for the we are grateful. And this is Fresh Waves Radio. This program comes up live on Thursdays, the same time, 10 a.m. West African time. So stay tuned, and the dial is still www.freshwavesradio.com. Thank you so much, Dr. Wimsala. Thank you.
Bye.